GP curriculum. I'm clinically retired. I'm no longer a GMC registered doctor, so nothing I say relating to anything, any cases is at all relevant. My background is of having been half-time as a GP and half-time in medical education, latterly as Associate Postgraduate Dean in the Deanery in Yorkshire and Humber. I still do coaching for those who want it in Yorkshire and Humber, and lots of stuff for green practice.
Brilliant, thank you.
So, teaching planetary health, that's what I've been asked to think about today. And my understanding is the evidence suggests that the conversations and learning goes best when we start where we have common ground, and that people respond to stories, not facts or theories. Indeed, if you look at most of policy making at the moment, it's based on stories rather than any facts at all. It's quite rare that a scientific opinion is found useful. So we need to remember that when we're working with people, whether we're teaching planetary health or whether we're working with patients around issues related to planetary health. So my suggestion is that rather than starting with all the theory and all the evidence and all the facts about planetary health, it's probably better to start with day-to-day work, but to bear in mind when doing that there is some evidence about what works in climate conversations. There's good evidence from the Exeter group that people enjoy a real conversation where you respect your conversation partner, you enjoy the conversation, you ask questions and you listen and show that you've heard. I guess that's probably just useful to say because that's what GPs try to spend so much of their time doing. So the way of having conversations, whether it's in the consultation room, on a street, or with trainees, I think is always going to be around having real conversations and making sure that we have a balance of addressing facts, feelings, interpretations and actions. And I heard Sally mentioning the test match, but there may be other people who would prefer to be thinking about football, so that's FIFA in the wrong order. So thinking and listening is really useful. Global warming is a wicked problem, and I think one of the things that we really need to help people think about is the reality of wicked problems. Wicked problems have a technical meaning. They're problems which don't have a single solution. The nature of what happens is changing. There are feedback loops, both positive and negative, which make it hard to say exactly where you are. So some things are not wicked. They might be complicated. Stopping West Yorkshire having any practices which are on the floodplain is probably a complicated or complex problem, but it isn't wicked. It's got a simple solution. Identify which ones, find the funding, do it. That's actually very simple. There's a few steps, but it's quite achievable. Whereas changing the nature of what people do in relation to sustainability is much more of a wicked problem. And when we're talking here, we want to think about not only the facts, but also the responses we get. And that's always the challenge of doing something on Zoom or on Teams. I can't see everybody's face. So I don't know how often I'm generating strong emotions or causing worry. But that's actually going to be very common, and we need to try and work with that rather than assume that we can solve, everything's just going to be a face-to-face, nice and clear conversation. So everybody, I think, hopefully was sent a link to the Bradford VTS site, which is a site where I largely wrote. Well, I did write, and Ramesh did the graphics and made it look pretty, because I don't do looking pretty very often. So it's a useful site. It's got lots of the theory, and if you want to go from the start to the finish, I think it'll give us lots of information. However, today I want to just share some ideas about why it might be good to go in a different way, and to share a way of doing presentations that I've been developing over the last few months. And this is probably quite familiar. You're in a GP consulting room in a deprived area. It's midsummer. There's a heat wave. I think this is just 10 days ago. It isn't the last 2 days, but it's the following are a list of the patients you're due to have contact with. And what I want us to do is for each of them to think about possible links to planetary health, given the principles of sustainable healthcare, how should we be approaching this? And I'm rattling through slides and this presentation very fast, so we've got more time for conversation. This isn't the speed at which I would be recommending doing. I think more space would be normal, but so that's the setting. I guess the other concept to remind us of is 2015 Montgomery verdict. UK Supreme Court said that patients must be advised about their treatment options and the risks associated with each option so that they can make informed decisions when giving or withholding consent to treatment. That's the basis of informed decision making. And I'm not sure we do that as often in primary care as we might want to, or we probably should do, in that we probably have a lot of patients who have asthma where we haven't said, and air pollution could be something that's related to this, or patients with many other diseases related to planetary health, where we haven't identified with them that there are causal factors which they may want to know about, and they may be able to make some political or actual personal changes which make a difference. So I think it's really important to think about that and to be aware that we should probably be doing more informed decision making than we do at the moment. Two core bits about planetary health. Planetary health is about what genetic changes to the planet have on the types of health problems we see. So the epidemiology of illness is changed by the change in the condition of the planet, but it's also about the way we practice healthcare changes the health of the world. So it is a two-way relationship, and 4 principles: prevention, self-care, lean service delivery, low carbon alternatives. I'm not going to spend long on that today, but I'm going to come straight to the first case, and maybe we should just pause and get people to write in the chat what they think is going on here. So it's a 12-year-old girl, poorly controlled asthma, presents asking what they can do to stop her coughing all the time. They live close to the main road in town. You note on her medication history, she's had 8 Ventolin pressurized metered-dose inhalers, 2 Clenil pressurized metered-dose inhalers in the last 6 months, and they're asking for some more cough syrup. So what are the planetary health questions that this makes you think about? And let's put some comments in the chat so that we can pick up on those. Oops.
Apologies, I can't seem to get on the chat at all. So
okay, well then just talk instead would be lovely. But I can't get onto the chat either, so that solves my problem.
I guess I'd like to explore a little bit about what the parents feel might be contributing to her asthma, and whether they've seen the link with living on a main road. And one way might be to ask them if they've noticed that she's better at different times of the week, depending on levels of traffic, perhaps.
Okay, so that's great, but we're making a connection there between the main road, and you're suggesting a nice, very ICE-centered approach to find out what their concerns are before taking it too far, so we don't jump in with size 21 feet and cause more problems than we've solved. But making a link with the main road. Any other links with planetary health here?
In the chat, Mike, both Sally and I had posted stuff about asthma control and also potential swaps from MDI to DPI. So yeah, both reducing her inhaler use by optimizing asthma control, but also by choosing inhalers which had a lower carbon footprint as well.
Lovely. So the pressurized metered-dose inhalers, there's lots of information about that, and the underuse of Clanil or of what traditionally, for some bizarre reason, doctors have always referred to as prevention, where I've never heard methotrexate used for treatment of rheumatoid arthritis talked about as your prevention drug. It's your treatment drug, and I don't quite know why we have a funny different language for asthma, which seems to minimize the treatment drug and the alleviator or the emergency drug, which might be, we're using some funny words which may not be the most effective for us, but another slightly stirring the pot question there that I'm giving. Any other planetary health issues here?
I'm not really sure if smoking, so the environment in the house, including smoking and mold, would be related.
Certainly, smoking is an important part of controlling her asthma and would be an important factor. And smoking is not good for you. It's not the number one top worry on a planetary health aspect, but it's certainly something which we should be thinking about if we're doing a holistic approach to care here. Tash, you've got a finger up.
Yeah, if this was in the context, if it was last week when it was really hot, yeah, there's the potential to open up the conversation about the changing climate and the impact of heat waves and really hot weather, and particularly thunderstorms on asthma control. That might be another way in.
So and if we were teaching with this slide, and I guess we can both do these slides as consumers and think about them as people who might be teaching other people about planetary health. This is a great stop-off point to start thinking about thunderstorm asthma and the smashing up of pollen and how that contributes to unexpected people getting asthma attacks, or people with established asthma getting massive unexpected deteriorations. I guess the last bit I was fishing for there was the cough syrup, because that's probably unevidence-based, but has a carbon footprint. So it's bad for it fails because it's consuming resources but providing no good, and therefore is an example of overprescribing. So switching, just to summarize that, we've got the 175 miles London to Sheffield, 4 miles London to another part of London, or Leeds to another part of Leeds. We've got the dose counters, we've got the disposal issues, we've got the fact that most people don't know how to use, most people using a pressurized metered-dose inhalers use it with a dry powder technique. So actually we have the wrong technique for the inhaler that they're using. And then we've got the Sweden, Norway, Denmark, 80% of their inhalers, dry powder inhalers. Indeed, in Finland, I was reading recently, the age for starting a dry powder inhaler. Can anyone give me a guess what the Finnish date is? Age is? It's 6. 12 in the UK. 6. Yeah. So we're still going with 12. And that's quite an effort to get people to say you can start it safely before they leave primary school. So there's some useful facts. And why is this important? Well, we haven't come to that yet, but if we look at the whole of the NHS carbon footprint, we've got 5% of the whole footprint is related to anaesthetic gases and metered dose inhalers. Of the whole of the UK's footprint, whoops, I think that's no, I haven't got that slide here. Whole of the UK, healthcare represents 3 to 4%. So it's the biggest single area of commissioning of the health footprint. So rest of medicines are about 20% of all NHS and about 60–70% of an average GP practices. So that's why looking at what we prescribe is so important. And that's why it's such a wicked problem, because you're not changing anything simple. You're changing the behavior of every doctor, every health worker, every physician's associate, every nurse, advanced nurse, everyone who has anything to do with repeating or supporting the continuation of medication through primary care. So it's an enormous challenge to change the behavior of that many people with the agreement of all of those patients. So it can't be done to them, it has to be done with them. So it's a really big challenge to try and make that happen. So just moving on, and there's 15 cases here. We're not going to do 15 cases today, but we'll do 1 or 2 and just see what it feels like. And then maybe Flick and just see some of the rest of them. So a 36-year-old man who just come back from southern France presents with a flu-like illness, describes feeling exhausted, fever, rash, vomiting, got bitten by lots of mosquitoes when in southern France, and feels just like he did on his gap year when lots of his friends got unwell in Southeast Asia. What's our presumed diagnosis? Or what might our presumed diagnoses be? Has he got flu? Is the diagnosis something funny, or have we got further than that? You've unmuted yourself, Sally, which is an indication you're about to say something.
Oh, no, I'm just thinking it's the implication that because of the climate change, the mosquitoes in the south of France are now more dangerous, so it's a mosquito transmitted illness.
The implication is that this is a mosquito transmitted illness, yes.
And I only know one mosquito transmitted illness, but
and that's fine to name that one mosquito linked illness, which is great. You've been the brave one who said anything. So the one that you know, of course, is dengue fever, and you'd be completely right that this is dengue fever.
Dengue, that's right. That's what I was going for. Yeah.
And malaria wasn't a bad idea either. So yes, the planetary health message here is that the epidemiology of mosquitoes is changing. There are now dengue is now endemic in southern France. Malaria is endemic in Spain. Can anyone tell me what thinking about the disease, the mosquito to either of the 2 mosquitoes are that spread?
Anopheles.
Anopheles is one, and the other one, you have to think of it's the second half is a country in the Middle East. That sometimes helps people to remember. But it might take them ages or ADs. Egypti, do you remember that one? Anybody got any idea how far up the Northern Europe that's got as an endemic mosquito? So who's gonna guess it's got to Aberdeen, Or Deborah, give me somewhere that it might have got to.
All the way to Norway.
Okay, not quite got to Norway yet, but it has got to all of the South of England and London and East Anglia. So we have endemic in the UK now, one of the 2 mosquitoes that spreads malaria. Okay. The other bit, I guess, that's quite important when we're thinking about disease spread and mosquito-borne illnesses is just to remind ourselves that the hotter it gets, the hungrier a mosquito gets. So they bite more often. And the shorter the life cycle is. In hotter weather, the time from egg to producing eggs is shorter by a day or so. So you get more mosquitoes breeding faster and they're hungrier. And it's only half of them who will bite you. But if there are more of them, that's more powerful. So there's some important things to consider there when we're thinking about what we can do to prevent it. And of course, there's other illnesses that's mosquito-driven, tick-driven. We've had tick-borne encephalitis is now identified in the UK. I'm old enough that my MRC GP included a question in the old oral exam. That really does date me on what did I need to know if somebody presented with a tick bite. And the answer was I needed to know whether they'd been abroad or to the New Forest, because the New Forest was the place, the only place in the UK that had Lyme's disease. It didn't exist outside the New Forest. It's now, yes, you can go up to Norway for that one, Deborah. So that's right the way up to the top. Okay, so nice bit just to think about there. One more, am I allowed one more before we go to some conversation, Sally? Would that be useful? I can stop it, or we can just look. So you had a 40-year-old asking for pain relief, multiple fractures, incident at work, rescuing people from a house locally when it was flooded, then collapsed 5 months ago. And I guess I'll make it easy. You might be thinking that he might have some post-traumatic stress disorder, which might be affecting his pain control. He's asking for more opiates. We know that opiates for chronic pain are not an effective method of treatment, so we shouldn't be. We should be thinking about other ways of managing his pain and other ways of supporting him and other ways of distracting him from things. We should be. So those would be some bits, and obviously the flooding makes you remember that actually the initial causes. So this is both being caused by planetary changes and is causing planetary changes in that we're giving him opiates which are causing problems. So we need to make a fairly full assessment for all of those reasons. It might take us to remembering that apart from antibiotics, I'm not aware of ever having prescribed a drug as a GP which is 40% effective. Antidepressants, 10%, 15% effective in reducing depression, whereas 48% for exercise. But it also does breast cancer, CHD, colorectal cancer, hypertension, diabetes, cognitive decline. We really don't sell exercise for the wonder of treatment that it is. Apart from to each other and as excuses for arriving late for meetings when we just run to them or been swimming for the day or whatever. So enormous benefits. And that may be something which we'd want to find a way to talk about with our firemen. Here's an 80-year-old presenting with the one-sided weakness of his face and slurred speech. Lives with a similarly aged wife, deprived neighborhood, being on treatment with a thiazide for hypertension, normally fit and well. What's the connection there with planetary health?
Is it to do with air pollution and stroke risk?
It could be because he lives in a deprived neighborhood. So that's one of the two things that I was hoping people would come up with. but the other one is also important to think about. And yes, you're quite right, Charlotte, to remind us that air pollution does cause some changes to asthma and COPD, but it also causes, and I just do some ones beginning with D, developmental delay, diabetes, dementia, depression, and anything else that you can think of that begins with D that's a medical condition, because it's likely to be increased. But what's the other one here for this 80-year-old man? I mean, what are we saying he's got? Are we saying he's had a heart attack? No, we're saying he's...
Had a stroke.
He's had a stroke. And just remember that the setting is that we're in a heat wave.
I forgot that. So he's dehydrated and he's on a thiazide diuretic.
He's on a thiazide, but actually all you need, you don't even need the thiazide. Anybody who's older in heat is more likely to have a stroke, because as we peripherally dilate, we put more strain on our heart, which has to pump, has a bigger circulation to pump the blood round, and is still trying to maintain the same pressure. So as we increase the temperature, we increase the work on the heart. If we increase the work on the heart, we're more likely to get heart attacks and strokes. So stroke increases because of heat. So there is a U-shaped curve of the connection between heat and deaths. Some of the extra increase is deaths borrowed from the next month, but some of it is people like this who are having strokes which might be fatal, or heart attacks. But if he had a stroke which is fatal, he wouldn't come to the GP surgery, so it didn't work for the cases that you're going to see, etc. So I don't think fetal growth retardation. There you are, developmental delay and growth retardation, both related to the air pollution. What can people do about air pollution? What reduces the air pollution that anyone's exposed to?
You can take personal steps for where you walk,
Yep.
so being further away from the flow of traffic, and trying to use minor roads and the time of day and that sort of thing.
Yep. Great.
Sort of on a bigger level, you know, at sort of locality change, there are moves towards clean air zones and
Yep.
campaigns
Brilliant.
at schools
Yep.
to stop engines idling, all that sort of thing.
Yep.
Those would be my initial thoughts.
And just think, are you better doing the commute to school in a car, on a bicycle, or walking? If you use the same route, which one will have the highest air pollution?
The car.
The car will have the highest air pollution, because cars will act as a box where you don't get the ventilation and you get a gradual build-up of air pollution inside the car, meaning that inside the car you have higher PM 2.5 and higher nitrous oxides. The only one that I would add to what you said, Sally, is if you have the ability to growing a hedge or having a hedge inside the front window, so either external or internal, but having vegetation between you and the road will reduce the amount of air pollution, because it breaks it down. Nice study done in Surrey last year which showed that. But yeah, vegetation can add, but not everyone has control over that. So not everyone has control. I'm literally now not going to, so that's some of these slides. I've got an information slide afterwards, just so that it isn't just Mike bullshitting or whoever it is using these slides bullshitting. There's some reminders that there's some evidence base to come back to. And here's a man with lots of drugs, and that takes us, he's obese, so it might take us to look at diet and healthy diet, and the footprints by diet of your meat lover down to your vegan, and not much difference in vegetarian and vegan. And you might want to then remember the lovely bit from donut economics, which is, yeah, it's all very, we've all got to live on this green bit, but to do that we have to have the bits in white and the green, which if we don't have, we won't achieve. So if we have not enough money, then we won't have enough food. So if we have too much inequality in income, then we won't have enough food, and everything you say about food won't make a difference because you can't afford a planetary health diet. And then round the outside you have the air pollution and the climate change, the ocean acidification and the biodiversity loss and freshwater withdrawal. So just to give us some things, this is a question about whether NSAIDs could be causing in the water, could be causing anaphylactoid type reactions. Just a reminder of the amount of pharmaceuticals we're here, just in case you'd lost us. Bright red, highest amount of pharmaceuticals in our surface water. If we look at that, etc., lots of them are caffeine, carbamazepine, analgesics, antibiotics, particularly NSAIDs, and anticonvulsants are the main things. And APIs is the active pharmaceutical ingredients. That's at level where they are pharmaceutically active, not they can be found. Yeah, eyebrows appropriately moving there.
So can I just ask, so how does the medication get into the water? Do we know?
Yeah, you know, because you're going to tell me how we break down our most pharmaceuticals come out in our urine. Some come out in our poo.
Okay.
And then they go from the urine, and they're not removed by our cleaning system because they're not required to be, because we're carbon driven, not health improvement driven in the targets we set the water companies, which of course they always achieve. Sorry, that was almost a political comment. I shouldn't have made that. That was naughty. So we can go on. There's a whole range of different prompts looking at TB or BCCs or post-traumatic stress disorder, or hay fever, or the consequences of being a asylum seeker or a refugee and having chronic kidney disease, or water damage and food poisoning. So lots of different cases. And I guess what I'm saying is it's more interesting to start with the story, and then you're more likely to remember the person with a stroke if you've seen a picture and we've had a discussion about stroke, than if I just say, and of course, cardiovascular workload will cause more problems. And then there's a reminder of greener practice. So that's a very quick run through of the slides there. And an indication of a case-led rather than a theory-led presentation for looking at planetary health.
Thanks ever so much, Mike. That's absolutely brilliant. I mean, I can see the versatility within the cases, how you could use them in different ways. Can I ask, with each case that you've very carefully constructed there to bring out all the different points, have you got a little crib sheet that for somebody who was wanting to use this to the max and might forget, for example, about planting a hedge? Have you do you have a little kind of answer sheet to go with each one?
So they come with notes on the slide deck. So the PowerPoint presentation, if you I was about to share it and show you that there's notes on most of them. I mean, on hay fever, reminding us that pollen is the hotter it is, the more pollen is produced. Long spells, no rainfall, increased pollution. It's why hay fever was first diagnosed in Manchester, not in London or anywhere else, because pollution activates the pollen sensitivity. So there's a crossover there. and you get longer allergy seasons. And there's a question with hay fever about, is it over medicalization of normal life? What about non-medical ways to control this? So those are the notes for that one. I can't guarantee that the plant, the hedges is in there, but some of my anecdotes are there, but I try not to have every anecdote that I might put in, because otherwise people try and do it and it doesn't fit for them. So there's a bit of providing enough to help people think, and a reminder that this is meant to be dengue rather than malaria, because malaria doesn't normally have a rash. So that made it more likely to be dengue than malaria. Although malaria is a good question, a good answer as well. So they come with prompts. So hopefully they're designed for anybody to use and to be quite available.
Has anybody else got any questions before we go into our thinking time?
No, regarding the virus, do you think it could have been Zika virus as well?
That's when it's really useful being able to say, I'm not a registered doctor, so I can't make a diagnosis anymore.
But because I'm just checking, and Zika is also comes from the mosquitoes aegypti, so yeah, transmitted.
Does Zika cause a rash normally?
I can't remember.
It just caused a flu-like illness, was my memory. But as I say, I'm not a doctor. I'm the least qualified person here to make to give an answer to that.
Yeah, it could cause a rash, fever, rash, headache, joint. Yeah.
Yeah.
So it could be.
It could be. It could be. It could be Zika. Thank you for reminding me of that.
So, Tash, were you going to speak?
Yep.
I was just going to remind people kind of the thinking time premise, and then are we planning to split into how many groups do you think?
I was dilemmaing between two and three groups. Maybe we'll split into three, and then that gives each person more time to talk.
Yeah. So if I just sort of recap on how we're going to run it, and then if you can remind everybody of the thinking time question.
Yeah.
So we'll break into three small groups and start with 3 to 4 minutes silence, and that's just to give everybody a chance to gather your own personal thoughts around the question, so that we don't kind of contaminate each other's thinking and end up with a narrower vista on what we generate in terms of our thoughts. And then if we go around the group one by one and let everybody share all their thoughts, and then if somebody from each group could kindly sort of summarize and feedback what the group feels is the best thinking from the feedback and any discussion that comes from that, if that makes sense. If it doesn't make sense, please say now.
Great. Thank you, Sally. So I'm going to create 3 breakout rooms. There'll be three or four people in each room. It'd be really good if when you first get into the room, you could agree who's going to take notes to feedback, because sometimes that bit gets forgotten. Our question today, it's kind of 2 interlinked questions, and I've posted it in the chat, but I'm just going to read it out loud as well in case you can't see the chat. Is how can we make best use of these resources to support us and our teams to embed these concepts in primary care? Who might we involve and how? So that's in the chat, or you could write it down. I'm happy to say it again if anybody needs me to say it again. Does anybody need me to say it again before I put you into groups? Yep. Okay.
Yes, Tash, please. I can't see the chat, but I've got 2 supporters and our teams.
Yeah. So how can we make best use of these resources to support us and our teams to embed these concepts in primary care? Who might we involve and how?
Primary care. Who? Yeah, might we involve? Yeah.
Okay. So, and what I'm going to do is we'll go into the rooms for about, it's 1:15 now, 20, oh, my maths is failing me, about 25 minutes, and then come back into these groups and I'll pull you back in, okay? So I'm just going to create the rooms.
Shall we make it 20 minutes?
Okay, 20, yep, 20. Okay, see you in 20 minutes. It was a relief when everybody starts reappearing. I always worry that I've made them all disappear. If I disappear for a few minutes, it's a bedtime related issue. I'm going to try and time it when Vina's doing feedback from our group. Okay. Great. So I hope that everybody's, is that all? 1, 2, 3, 4, 5, 6, 7, 8, 9. That's pretty much, we've lost Sarah somewhere, but hopefully she'll reappear. So I think that's everybody back from the groups. So if everybody who took notes could feedback the conversations in theirs, actually, would you mind going first from our group, Vina, while I just check on what's going on upstairs?
No, not at all. Hi, so in our group, we looked at it from different perspectives. So one of our group found the cases really interesting and identified particular cases that she thought she would use both for her own learning, but also to be able to share with the wider team. And the one that jumped out at her was the asthma care one, using it as a tool to stimulate discussion and learning around inhalers and changing them and changing prescribing practices. Thinking particularly about aiming it towards nurses, but also then as the discussion went on, we realised that involving the pharmacists in that would be really important as well. And then just the fact that all of us were quite blown away by some of the kind of things we learned tonight, and the levels of medications in water was one of them, and that using that in a conversation with patients and pharmacists to try and encourage deprescribing. And also, you know, using it, the case study about the mosquito bites in health promotion on a day-to-day level. From an educator's point of view, we were looking at where we could share some of these great slides and cases, and we thought about GP registrar tutorials, medical student tutorials, whole team meetings, and going up the level to PCN level meetings, target meetings, possibly within Leeds, LMC meetings, trainers groups, trainers away days. So basically everyone we could possibly get to, I think. Maybe picking out cases from the slides what relevant to the groups, or spreading them out and doing small group work. So in terms of who we would involve, hang on, let me just see, I'm looking at my notes, just make sure I missed anything out. Yeah, so who would we involve? Well, we'd want to involve the whole team really, but specifically clinicians, nurses, pharmacists, a group, and social prescribers as well, to get that message through to them as well, to promote a lot of the healthy living messages. Just trying to have a look through my notes, see what else I've said. Oh yeah, also maybe the patient group as a form of interested in discussion with them, so that they can spread it with their peers as well. One of our group also suggested maybe sharing some of this information with local community groups, and cautiously on social media as well, without trying to instill panic amongst the local population. I think I've covered everything, have I, guys? I'm not sure. Have I? Yeah.
Great. And could we have feedback from one of the other groups?
So yeah, I don't want to repeat what Vina said. We covered some of the same territory there, but in Leeds, we're obviously quite lucky that we've got quite good channels. We've got the primary care bulletin, we've got Target, we've got Optimize RX to remind us of good prescribing. We're also quite lucky that the local guidelines have been changed to sort of align with good inhaler prescribing. So if we stick to that, then we'll do the right thing. So we've thought about involving meds management teams in the wider sense, the pharmacists who do a lot of the prescribing. We also thought about the social prescribers maybe helping with the patient participation groups. The cases Mike, they really lend themselves because they're not too clinical. So I think even a non-clinical person with no medical training can sort of understand what the topics are. So you can have a discussion about that. We thought about posters, we thought about going out to baby groups, maybe to local groups, to discuss the issue. So the cases are really good in that way, because you don't need to have a lot of knowledge to sort of understand what it's all about. I think we're very lucky tonight again that we've got Kirsty here, Kirsty Turner, because she's been a real a champion for greener practice causes, and we all have really benefited from that. She's sort of just been really supportive of initiatives. So I'm glad that she's here again tonight. We did talk about the VTS training scheme and using the resources in training for in-house e-learning we mentioned. So yeah, lots of channels to spread the news. And Mike, the cases are really good because they're so usable for non-clinicians. Anything else, Sally, or Sasha?
No, I think you covered it with the kind of broad brushstrokes. That for me personally, it sort of stands out that there are some trainers who are taking an active interest in this, and some who I feel like they're leaving it to other people. And it would be great if it just becomes more universal. So for me personally, I was thinking about using this presentation in-house with my other trainers. So I've got 3 other trainers, and just going through it with them, because then I think that would give them the confidence to take it and run with it. So yeah, you can use the VTS as a bigger platform. But if if there was a sort of champion in each practice who was willing to do that through the trainer network, I think that would be really effective. So that's my plan.
Just one other thing that we mentioned was this, this almost like a sort of tightrope. Where do we, the GP also as a citizen who's also affected by climate change, not just somebody who's handing out advice to patients, but we're also affected, and we're citizens in the same situation as everybody else. And it then depends on how politically active we should or can be as a GP. I know that you mentioned, Sally, that part of the greener practice toolkit is that one option is to declare climate emergency on your practice website, and not everybody may want to go that far. Probably also depends where you stand politically and all the rest of it, but that I also wanted to mention that it's lots of aspects, not just handing out information, but also being in the same position as everybody else.
Thank you, Annetta. There should be one other group to feedback from? Okay,
I'm feeding back from our group, and as always, I always feel a bit of a fraud because I'm not a clinician. So and I'm really struggling now, going last in terms of picking out the things that's different for us, because I think we definitely were talking about kind of getting the message out there. I was fortunate enough and slightly intimidated because I was in Mike's group as well, so kind of the pressure's on to be really kind of on it. But I suppose we definitely covered everything. So target, I think, I know this was about training and kind of getting it out on the VTS, but I think this should be put on the target website in the same way as sometimes the videos go on there, just because it's a resource that everybody then could use. And I think certainly I think the case studies really lend themselves just to engaging with clinicians. So whilst I think, Annette, you were just talking about community groups, I think we also went kind of, why are we not trying to go to the exec board of the ICB? Why are we not trying to take this to the clinical lead forum? Because again, you can pick up those interests around respiratory, cardiovascular, and it's not just the planetary health, is it? It's kind of, how is this embedding population health as well? I think the other bit that again, linking back to Anetta's point that she just made about how political, we had a bit of a conversation around how do you engage patients in, or what's the conversation around this is linked to climate change, and Mike talked through some of the scenarios of how you might want to present some of that conversation. So again, this for me feels really holistic in terms of a conversation, doesn't it? Because it is, and I'm completely pinching everything that Mike's said a little bit around, is that patient-centered conversation, and the what matters to you conversation. So yeah, I think ultimately, I think we all agreed, great resources. Again, Mike was saying, let's make it fun as well. You can have some fun with some of the resources, and in terms of the case studies, but you can also, again, totally nicking his words, but you know, create your own case studies as well to help consolidate your thinking as well. And so there's lots of ways to take it forward. But yeah, ultimately, I think far and wide, it's a great resource to use that kind of really helps embed some of the agenda. I think, you know, makes it more mainstream, doesn't it? So yeah, I think please pick me apart however much you want, Mike. Claire.
I couldn't, because I think the only thing that you didn't say is how important it was for us to try and get an audience with managers, because managers make so much difference. But you were too polite to repeat that quote.
Thank you.
Sorry, Tash, I was just picking up on that point about coming up with your own cases and things. I don't know, are there any plans for the case-based discussion format to change so that it includes a domain that where you might be able to demonstrate your thinking around planetary health and sustainable healthcare?
Not that I'm aware of. There is discussion about, and I'm now going to have to admit to another finger in another pie. I used to be one of the people writing the workplace-based assessment side of the college exam, and I am working with one of the people who still do that to try and encourage them to change some of the capabilities, the competencies, so that they more overtly look at, particularly at prescribing and overprescribing and overdiagnosis. And so to make the word descriptors cover more of planetary health, rather than to add a new area, just to make the existing areas better focused on this big challenge to the whole health service, the one that Antonio Guterres says is the biggest challenge facing humankind.
Thank you, Mike, and thank you, Kirsty, as well, for summarising. So it seems like there was overlap in the discussions between the different groups, but also lots of interesting different ideas coming up in different groups, and you know, a wealth of ideas of where we can take this resource and how we can use it, which really speaks for, you know, Mike's work on this, because he's created something that is so flexible, and I think could really help develop people's thinking and ideas in a gentle way. And I guess the question is, where do we take our discussions from tonight? I think all three groups talked about target, and in previous meetings we've talked about trying to have one of the Leeds targets on something around greener practice, and I think that this resource would be a fantastic resource to use in that way. So I think, I don't know if Kirsty, if that's something you could help us take forward, and Sarah in our group has raised that also Nicola Bainbridge, who's on the LMC, is also part of the target group. So it'd be really nice to work towards that actually happening, if possible, a face-to-face one. maybe we wouldn't be the whole of the whole target session, but yeah, to have that platform, particularly if we had in a way where we could do smaller group work, would be really good. Sarah, who's not, Sarah rejoined us? No, Sarah also talks about possibly an LMC meeting about it, which would have a reach to, you know, I guess they all have reach to different GP groups, don't they? And I think, yeah, this evening certainly made me feel excited about the possibilities. Sally and I were actually asked to do something on greener practice for the Leeds Trainers Away Day, and are planning to use some of Mike's scenarios for that. If that's all right with you, Mike, hopefully. Yeah, so it'd be really good. I don't know if there's any other things that people would like to see as kind of concrete things that come out of this meeting.
Those sound like really good things to have as outcomes, and if you want me to come and do them, or be part of them, that's always a pleasure. It's a little while since I've done. I used to do lots of Leeds trainers meetings. So that'll be a different hat, and quite fun to do it in a different way.
Kirsty's got a hand up.
I suppose just to confirm, I'll pick back up the target conversation, just either a planetary health focused target conversation. I feel a bit out of touch in terms of what the plans are in terms of face-to-face and things like that now, which I know I should know, but I will do that. I would also like to explore, and I don't know how we can, but I can ask the question. Just, I know, as I said, the ICB clinical leads and some of the general, and Etta, I don't know if you know how often or when this happens, but it feels like a real opportunity with some of the population board representatives and the clinical leads. I think there's different forums where they do get together, and I think this would be a good way to engage some of those other clinical leads in leadership roles. So I'll take away her conversation. I'll come back to you if that's okay. I just think it'd be a good forum to try. Sorry, I'm sounding vague. It's because I just know it happens. I'm just not well connected to it, but I'll make some conversation, then I'll come back to you.
Fantastic. Thank you, Kirsty. And Sally, you've got your hand up as well.
Yeah, it was just to mention as well, there is another Leeds, sorry, this is Leeds based, but Planetary Health Day planned for October, I think. I'm actually away, but I know that it's the same people that are working on it as last year. So Mike, you'll be aware of this probably. It's Honey and Artie and Matt and Margaret. I mean, this would be perfect to use in that, wouldn't it?
I think I'm involved. Well, I was involved last year in doing the that was the all Yorkshire and Humber Planetary Health Day, wasn't it? All trainees.
It was Yorkshire and Humber, yeah.
And yes, I'm part of the group, and so I was hoping that I might be able to offer this as one of the as an afternoon workshop, to do it a couple of times there.
Yeah, brilliant.
Great. So that feels like there's some really concrete ways in which this is going to be, you know, that we've all got ideas about how we're going to take it forward on personal levels, at practice level, and then at larger scale levels, with some clear ideas of using it at Trainers Away Days, targets with the ICB Clinical Leads Forum, and at the Yorkshire and Humber Trainee Day on planetary health. I don't know if there's anything else anybody wants to, I'm just aware of time, and it is, yeah, just giving people a bit of time before their next working day tomorrow. Yeah, I just want to thank everybody for their contributions this evening, and particularly Mike for developing such a wonderful resource and coming and talking. Debbie?
Yeah, it's just a quick thank you. I always feel very inspired by, you know, people like you that fight the good cause. So it's thank you so much. And did you mention Antonio Guterres' quote? Could you repeat that, because I missed it?
I might not have got it right, but but my memory is that he said that that planetary health is the biggest challenge facing humankind.
Right, right, okay.
Um,
Very intelligent man, isn't he? Okay.
If I've got my computer.
Don't worry.
I can find it and put it on the bottom of the minutes.
Thank you.
He certainly said it's. I mean, he also joined Doctors for XR, so he has got the message that something needs to be done. Although I don't think he would support anyone upsetting Sally's enjoyment of Test cricket. So no test activities during the Test match. I think might be his might be Sally's request, but.
I studied with his daughter, so I'll mention to her your comment.
But he's a fascinating and brilliant man.
And
all the people who do the sort of things I do can only do it because we know that there's people in Leeds and in Bradford and in West Hertfordshire who are supporting us and enabling us. The energy comes from being engaged with people like you who spend time in the evenings, and that's what makes it worth doing. So my energy comes from being supported by you, not the other way around. I gain from you and want to thank you for all that you do.
Thank you.
Thank you, Mike.
Thanks so much, Mike.
Okay, well, thank you everybody for joining us this evening. And yeah, thank you for all your contributions, and we'll take things forward from here.
Lovely to see everybody.
Sally, can I just check one thing? Do you want me to send you the version with the slides at the beginning about why I use this approach, or just the presentation?
I think everything would be really helpful.
Okay,
yeah,
lovely.
if you don't mind.
And do you want it as a PDF or as a PowerPoint?
PowerPoint, if possible, that would be amazing.
It'll be sent as a Google Drive link because it's too big to come as a presentation any other way.
Yeah. Okay. Brilliant.
Okay.
Thanks so much. Are you in the house where I came to visit you?
Yes. Yeah.
Yeah. I don't recognise that. That was probably the room we weren't in.
You didn't come into my study very much, no. So this is this is a study, and it's the room I've always used. I used to be that way around, so we just moved it around just a little bit. Yeah.
Yeah. It's really nice to be able to kind of envisage where you are though as well. Yeah. Thank you so much, and hopefully see you again soon.
See you soon. Take care.
Take
Bye
care.
now.
Bye-bye. Bye.